In 1962, the medical community introduced a term that would unintentionally narrow the clinical perception of joint disease for decades: the pseudogout syndrome. It framed a complex, highly prevalent crystal arthropathy as a mere imitation of another condition. Calcium pyrophosphate deposition disease, or CPPD, is actually the third most common inflammatory arthritis. Yet despite its high prevalence, it remains one of the most under-recognized conditions in rheumatology. This lack of recognition stems from the fact that CPPD presents with a wide spectrum of clinical manifestations, frequently appearing as a proxy for several other distinct joint diseases. Improving patient outcomes requires moving past the monolithic pseudogout label. Modern management depends on identifying specific clinical phenotypes and utilizing targeted imaging to confirm the presence of crystals. Reducing CPPD to a single acute event ignores its chronic and mechanical variations, which often leads to inaccurate diagnoses and ineffective treatment plans. To manage this complexity, EULAR established 4 distinct clinical phenotypes. The first is asymptomatic CPPD, a common incidental finding in roughly 10% of patients in their 60s. The second is osteoarthritis with CPPD, presenting as a slow, progressive joint destruction, mirroring traditional wear and tear. However, there is a key mechanical distinction. While primary osteoarthritis usually targets the medial compartment, causing a varus deformity, CPPD-associated osteoarthritis frequently affects the lateral compartment, resulting in a valgus deformity. It also appears in joints typically spared by standard wear, such as the wrists, the shoulders, and the metacarpophalangeal, or MCP joints. Looking only for traditional medial joint wear guarantees these atypical distributions will be misdiagnosed. The third phenotype, acute CPPD, traditionally called pseudogout, accounts for 25% of cases. Unlike gout, a CPPD flare takes longer to peak and can persist for up to 120 days. The fourth phenotype is chronic CPP crystal arthritis, presenting as a symmetrical, deforming polyarthritis. Because it involves the MCP joints and exhibits sequential flares and synovial thickening, it is frequently mistaken for rheumatoid arthritis. This diagnostic trap deepens because 10% of older CPPD patients show a positive rheumatoid factor simply due to their advancing age. Relying on this blood test without specific imaging misdirects patients into a rheumatoid arthritis treatment pathway they do not need. To prevent misdiagnoses, the focus must shift to the direct identification of the calcium pyrophosphate crystal. Synovial fluid analysis using polarized light microscopy is the traditional gold standard, but it has a high false negative rate. Crystals are sparsely distributed or hidden within cellular vacuoles, requiring significant time and expertise to find. Even when visible, they appear as faint rhomboid shapes with a very weak positive birefringence. Standard X-rays are also limited, identifying only about 40% of clinically important CPPD cases. Targeted ultrasound has emerged as the superior screening tool, offering a much higher sensitivity. OMERACT working group data shows that scanning the medial meniscus, wrists, and symptomatic joints provides diagnostic accuracy exceeding 90%. In specialized settings, dual-energy CT can even differentiate between these crystals and other forms of calcification. Transitioning from standard X-rays to these targeted ultrasound protocols is the most effective way to stop missing active CPPD cases. The most significant challenge is the absence of any disease-modifying drug capable of reducing the crystal burden. For acute attacks, EULAR recommends suppressing inflammation using low-dose colchicine, NSAIDs, or corticosteroid injections. It is important to note that these treatments are largely based on expert opinion and data extrapolated from gout trials. For severe cases, clinicians may use interleukin-1 inhibitors like anakinra off-label. Managing chronic cases involves a step-down approach using low-dose steroids, methotrexate, or hydroxychloroquine based on limited trial evidence. Until pharmacology can target the crystals themselves, clinicians must balance these off-label therapies against the complex health needs of elderly patients. For every new diagnosis, especially in younger patients, there is a critical secondary step: screening for metabolic triggers. Testing for hyperparathyroidism, hypomagnesemia, and hemochromatosis is essential to identify the root cause of crystal formation. To improve care, we must adopt a new workflow: leave the pseudogout label behind, map the patient to one of the 4 EULAR phenotypes, and use targeted ultrasound as the primary diagnostic tool. There is currently an international effort to establish a unified set of classification criteria for the disease. This unified classification is the necessary foundation for building the well-defined patient cohorts needed for large-scale, randomized controlled trials. By adopting these rigorous diagnostic standards today, the medical community builds the framework required to eventually develop true, disease-modifying treatments for CPPD.